Hello everyone and welcome to lecture 49 of this series of lectures on fluids, electrolytes, and acid-base disorders. This series is based on my book, Manual of Fluid, Electrolyte, and Acid-Base Disorders, a pathophysiologic approach to common clinical problems. I'm Dr. Mohammad Tinawi. I'm a nephrologist in Northwest Indiana. This is the book. You can find it on Amazon. Please follow the link below. It's available as an ebook and hardcover. Both are in full color, and also there is a paperback edition. We are still on Chapter 7, Hypophosphatemia and Hyperphosphatemia. And today we are going to finish phosphate homeostasis. So this is part 3 of phosphate homeostasis. So like we said before, the kidneys are the main regulators of phosphate homeostasis, and we have 3 hormonal systems acting to regulate phosphate: the parathyroid hormone, calcitriol, and then FGF23/clotho. Now let's see what goes on in the kidneys. Most of the filtered phosphate is reabsorbed in the proximal tubule, so 85%, the majority of it. 10% is reabsorbed in the loop of Henle. Now the distal convolute tubule reabsorbs 3%, and the remaining 2% is reabsorbed in the collecting tubule. Now the amount of phosphate excreted in the urine equals the net amount of phosphate uptake by the intestine. This is what happens in a steady state. So we said if we have someone taking 1,000 milligrams of phosphate, 400 milligrams will go into the stool, and 600 milligrams will be uptaken by the intestine, and that same amount, 600 milligrams, will go into the urine. Now, phosphate reabsorption in the proximal tubule is an active process. It happens via the transcellular route, and it requires the movement of sodium down its concentration gradient. Now, how does that happen? The apical brush border of the proximal tubule contains 3 different phosphate cotransporters. Cotransporter because the transportation happens with regard to sodium and phosphate. So sodium goes in and phosphate follows. So here in the kidneys we have NPT2A, NPT2C, and PIT2, or phosphate transporter 2. Like we mentioned before, the NAPI2B or NPT2B exists in the small intestine. So B is in the small intestine, or 2B is in the small intestine, while 2A and 2C exist in the kidneys. Now, factors that decrease renal phosphate reabsorption include high phosphate diet, parathyroid hormone, and FGF23. So we said PTH and FGF23 are phosphaturic, and if you're eating too much phosphorus, then you are going to excrete more of it. And how does that happen? It happens by downregulating these cotransporters. What cotransporters? NPT2A, NPT2C, and PIT2. Now the reverse is true. Factors that increase renal reabsorption of phosphate include low phosphate diet and calcitriol. And they do that by upgrading these 3 cotransporters. Now this diagram summarizes what we talked about. The proximal tubule reabsorbs 85% of the phosphate. The loop of Henle reabsorbs 10%. The distal convolute tubule 3%. And finally the collecting tubule 2%. Now we'll discuss phosphate pathophysiology in chronic kidney disease. I kind of alluded to all that in the previous lecture. In patients with chronic kidney disease, serum calcium decreases due to decrease in calcitriol. When you have chronic kidney disease, you are going to make less 1,25-dihydroxyvitamin D3 or calcitriol. Also, when you have a decline in GFR, phosphate is going to increase, is going to accumulate. So now we have a decrease in calcium, and we have an increase in phosphate. This is going to stimulate PTH secretion. How? By acting on the calcium sensing receptor. When you have an increase in phosphate and an increase in parathyroid hormone, you are going to stimulate the production of FGF23 from the bones. Now, in turn, FGF23 is going to reduce calcitriol and is going to reduce PTH secretion. Now, it's going to reduce calcitriol by inhibiting renal 1-alpha hydroxylase and stimulating 25-hydroxylate. When calcitriol synthesis is inhibited, you are going to inhibit intestinal phosphate absorption, and you are going to subsequently decrease phosphate. Now, like we said before, the rise in FGF23 occurs early in the course of CKD, as early as CKD2. Now, FGF23 is independently associated with increase in mortality. When the level goes up, mortality goes up, initiation of dialysis and cardiovascular events in patients with advanced CKD. Now, in patients on hemodialysis already, increased FGF23 levels are associated with an increase in mortality. I showed this very important slide in the previous lecture. I'm going to show it again. FGF23 in the red goes up first in stage 2 chronic kidney disease. Then you have a decline in the level of 1,25-dihydroxyvitamin D. Then you have an increase in parathyroid hormone level. Now, PTH is phosphaturic. 1,25-dihydroxy-D is also phosphaturic. This initially is enough to prevent the increase in phosphate. But once you reach stage 4 and higher chronic kidney disease, phosphate is going to go up. And these mechanisms will not be enough to stem the tide of high phosphate. Now, in patients with chronic kidney disease, FGF23 is going to increase, but also you are going to have a decrease in klotho expression in the kidneys. And this is an early marker of chronic kidney disease and chronic kidney disease mineral and bone disease, also known as CKD-MBD. Now, klotho is important because it may protect against renal fibrosis and may inhibit vascular calcification. So it's possible that one of the mechanisms of renal fibrosis, of renal scarring in patients with chronic kidney disease is the decrease in klotho expression. Like we said before, PTH and FGF23 will result in phosphaturia, an increased phosphate excretion in the urine. Why do they do that? They decrease the number of sodium phosphate cotransporters. We just talked about these 3 transporters in the proximal tubule. And when that happens, you are going to have increased phosphate excretion, and this will limit the rise in serum phosphate. Now, when renal function worsens, the above will not be enough to mitigate the rise in serum phosphate, and hyperphosphatemia ensues. And this happens again in patients with stage 4 and higher. Now, the kidneys are working hard in advanced chronic kidney disease. The fractional excretion of phosphate can be higher than 60%, and yet that will not be enough to keep phosphate in the normal range. Patients with stage 5 chronic kidney disease and patients on renal replacement therapy, whether it's hemodialysis or peritoneal dialysis, have certain features. Calcium is usually low or low normal. Usually it's not high. Phosphate is high unless you are giving phosphate binders. PTH will be high, and FGF23 is high. Now, this constitutes secondary hyperparathyroidism. So primary hyperparathyroidism, you have a parathyroid hyperplasia or adenoma, PTH rises, and then subsequently you have high calcium and low phosphorus. Now here, the mechanism is totally different. You have a decrease in calcitriol, you have high PTH, you have low calcium, you have high phosphorus. So when we have a patient with high PTH and chronic kidney disease, we're going to look at the calcium and phosphorus. If the calcium is low or low normal and the phosphate is high, this is probably secondary. If we see a patient with chronic kidney disease on high calcium, then we should indeed look for primary hyperthyroidism, and over the years I've found a few cases. If the patient still makes urine, measuring urine calcium is helpful because it will be elevated in primary hyperparathyroidism. Now, when you have these derangements, you are going to have what we call chronic kidney disease, metabolic bone disease, CKD, MBD. Now, the parathyroid glands increasingly become resistant to the effect of FGF23. So with time, FGF23 will no longer be able to suppress PTH like will happen early on, and this will worsen the secondary hyperparathyroidism, because when FGF23 is not able to suppress PTH, phosphate is going up, and when phosphate goes up via acting on the calcium sensing receptor, like I explained 2 lectures ago, is going to increase the level of PTH, and this will worsen secondary hyperparathyroidism. How do we treat secondary hyperparathyroidism? We treat it with calcitriol or other vitamin D sterols. So calcitriol is what the body makes. It's 1,25-dihydroxyvitamin D3, and it is available either as a capsule or as an intravenous medication. But there are other synthetic vitamin D sterols like doxorcalciferol, also known by the trade name Hectorol, and also is available orally or intravenously, and pericalcitol. Pericalcitol is known as Zemplar and also is available orally or intravenously. So most dialysis patients, probably 70% or so, are taking some form of vitamin D calcitriol, doxorcalciferol, or pericalcitol. Now, with secondary hyperparathyroidism, we are going to control the phosphate with dialysis, diet, and phosphate binders. We are going to give some form of vitamin D, and we are going to follow PTH every 1 to 3 months. If that is not enough, we are going to use a calcium mimetic. So a calcium mimetic is a medication that reduces PTH by activating the calcium sensing receptor. So when the calcium sensing receptor is activated, PTH is going to go down. And so far in the United States, we have 2 compounds. We have cinacalcet, also known as Sensipar, and it is available as an oral medication. And we have etelcalcetide, which is an intravenous medication, and both are very effective for treatment of secondary hyperparathyroidism. So first thing, you are going to do phosphate restriction, diet, you add vitamin D. If PTH is not controlled, you are going to add a calcium mimetic, and a calcium mimetic is going to activate the calcium sensing receptor and decrease PTH. Now, if that yet is not enough, then you can consider surgical referral for parathyroidectomy. Usually they remove 3.5 glands. So these are the different treatment options for secondary hyperparathyroidism. I'm going to end here, and in the next lecture, we are going to start our discussion of hypophosphatemia. See you then.